Let's get right into it. In this explainer, we're executing an integrative mixed block simulation, and it is calibrated strictly for a 270-plus score. We're bypassing the basics today to establish a strict peer-to-peer professional baseline. The clinical material we're analyzing requires absolute precision. We'll dissect the high-stakes diagnostic variables, discrete management steps, and the precise mechanisms that completely separate an average performance from top-tier clinical mastery. Let's begin.
To hit that 270-plus tier, having just a generalized understanding of disease states, that's completely insufficient. You have to isolate the strict diagnostic variables. I'm talking about the exact clinical markers, the enzyme deficiencies, the specific toxic accumulations, and those incredibly subtle physical exam findings that differentiate nearly identical presentations. Mastering this isn't just about grabbing points on an exam. It's absolutely crucial for saving lives in the clinic by preventing catastrophic mismanagement. So we are going to consistently detail the intricate mechanisms and classic exam traps that dictate correct clinical management.
Module 1. Macrophages and Bone Crises.
Let's analyze the precise biochemical mechanism of Gaucher disease. As you probably know, this is the most common lysosomal storage disorder, and it's strictly driven by an autosomal recessive deficiency in the enzyme glucocerebrosidase. When this enzyme fails, the lipid glucocerebroside invariably accumulates right inside the reticuloendothelial system. It specifically targets the brain, liver, spleen, and bone marrow. And it's exactly this specific substrate accumulation that drives the entire clinical picture. So what does this actually look like clinically? Well, those engorged macrophages aggressively infiltrate the bone marrow. Under a microscope, these lipid-laden cells take on a highly pathognomonic, crumpled tissue paper appearance. These are your classic Gaucher cells. Because they essentially take over the marrow, the strict clinical signature includes severe pancytopenia, most notably anemia and thrombocytopenia. The patient is also going to exhibit profound hepatosplenomegaly. But here's the absolute distinguishing hallmark the trap examiners love to use to test your mastery: exquisitely painful bone crises. This frequently manifests as avascular necrosis of the femoral head.
Module 2. Neurodegeneration and Macular Variants.
This brilliantly illustrates the kind of clinical variance you have to master. We're contrasting Niemann-Pick disease and Tay-Sachs disease. Both of these autosomal recessive conditions feature devastating, rapid neurodegeneration and an absolutely identical infantile cherry red macula. So what's the variance? The sole defining diagnostic variable in a clinical vignette is actually the abdominal exam. Niemann-Pick strictly features massive hepatosplenomegaly because of that systemic macrophage involvement. Tay-Sachs, on the other hand, strictly spares the liver and spleen, presenting with a completely normal, benign abdominal anatomy. Lock that distinction in right now. Let's break down the sphingomyelin matrix in Niemann-Pick. The disease is driven by a deficiency in sphingomyelinase, which leads to the accumulation of sphingomyelin cholesterol in the reticuloendothelial and parenchymal cells. The macrophages here appear as lipid-laden foam cells. In type A disease, you're going to see an early onset with rapid neurologic deterioration, areflexia, and neonatal jaundice. It is exactly that systemic reticuloendothelial involvement that guarantees the massive hepatosplenomegaly you will palpate on exam.
Conversely, look at the GM2 ganglioside trap in Tay-Sachs disease. This one is driven by an absence of hexosaminidase A. Infants may appear entirely normal until about 3 to 6 months of age, at which point profound weakness kicks in and development aggressively regresses. A highly specific clinical marker you need to watch for here is an exaggerated startle response or hyperacusis to loud noises. But remember our structural trap. Tay-Sachs completely spares the liver and spleen. The abdomen will be completely flat and soft.
Module 3. Lethal viral neuroinvasion. Let's shift gears to an acute immunologic management protocol. Before we look at the strict management mandates, we have to understand the neuroinvasion mechanism for suspected rabies. The virus strictly binds to acetylcholine receptors right at the neuromuscular junction, and then it travels directly via retrograde axonal transport straight to the central nervous system. This causes severe progression to confusion, coma, or seizures. But here is the absolute prophylaxis mandate you cannot miss. An exposure does not require a visible bite. Because bat bites can be entirely painless and microscopic, simply waking up in a room with a bat strictly constitutes a high-risk exposure requiring immediate action.
Observe this strict clinical algorithm. If the animal is known and healthy, you quarantine that animal for 10 days for observation. You do not initiate prophylaxis. However, if the animal is unavailable or tests positive, the patient requires immediate post-exposure prophylaxis, or PEP. The immunologic sequence is critical here. An unvaccinated patient absolutely mandates both rabies immune globulin, HRIG, to provide immediate neutralizing antibodies, plus the full human diploid cell vaccine series to mount active immunity. By contrast, a previously vaccinated patient, say a veterinarian or a spelunker, strictly requires only 2 booster doses of the vaccine and absolutely 0 HRIG.
Module 4, the master case blueprint. Let's bring all these metabolic variables together into a final, rigorous assessment.
Here's the structural blueprint of our master case. Step 1. A 10-month-old infant is brought in with an aggressive loss of motor milestones. Step 2. The physical exam reveals a severe, exaggerated startle response to loud noises, and fundoscopy confirms a cherry red spot on the macula. Step 3. Here comes the trap. The prompt meticulously describes a completely soft, flat, and benign abdomen. The liver edge is unpalpable. This single physical exam finding aggressively and absolutely rules out Niemann-Pick disease, trapping the unwary student who simply memorized the cherry red spot and stopped thinking.
And this brings us to a highly competitive 5-option matrix, simulating real exam conditions. The prompt asks for the specific deficient enzyme. Let's do an exhaustive choice-by-choice breakdown to bypass the traps. Option A, sphingomyelinase. This is your classic distractor. This deficiency causes Niemann-Pick, which definitely shares the cherry red spot neurodegeneration, but we just established the abdomen is perfectly benign, so we strictly bypass it. Option B, glucocerebrosidase. We know this causes Gaucher disease, which presents with bone crises and pancytopenia, not an isolated cherry red macula. Option C, alpha-galactosidase A, leads to Fabry disease. That's characterized by neuropathic limb pain and angiokeratomas. Option E, RL sulfatase A, causes metachromatic leukodystrophy. This leads to ataxia and dementia due to demyelination and completely lacks the cherry red spot. Therefore, the strict, undeniable answer is option D, hexosaminidase A. This confirms Tay-Sachs disease, correctly identifying the GM2 ganglioside trap.
To wrap up our explainer today, I'm going to leave you with this final provocative clinical query. Think about this. If a different infant presents with devastatingly painful bone crises, severe pancytopenia, and a bone marrow biopsy revealing pathognomonic crinkled paper macrophages, exactly which biochemical substrate is now accumulating in their reticuloendothelial system? Master precise distinctions like this, and your clinical execution is going to be absolutely flawless. Until next time,